All right, good afternoon, everyone. We'll go ahead and get started. Our topic for today is heart failure. And so let's begin our discussion on heart failure. So, heart failure is a syndrome. So, when we say syndrome, it's a collection of symptoms of fluid overload or of inadequate tissue perfusion. And heart failure is the inability of the heart to pump sufficient blood to meet the needs of the tissues for oxygen. Now, we used to call it congestive heart failure, but it has been found out by evidence that the term congestive is no longer appropriate because not all cases of heart failure results in congestion. This is from the 2013 heart failure guidelines of the American College of Cardiology and the American Heart Association. So there are two problems that usually occur when we have heart failure, and that may be contraction of the heart muscle, meaning to say that it's a problem of systole or contraction. And the other one is a problem of filling of the heart. And this is what's called diastolic dysfunction. And so it is going to be imperative for us to discuss both of these particular heart failures, and therefore we're going to talk about them in detail. But before we go there, let's go ahead and talk about some important terms in order for us to understand what heart failure is. And the first one is cardiac output, then stroke volume, and heart failure. So when we talk about cardiac output, what is it? Well, cardiac output is the blood volume that's pumped out of the heart in 1 minute. And it's the product of two things. And let me just write again. So cardiac output is a sum of the stroke volume times the heart rate. So what is stroke volume? Well, stroke volume is the volume of blood that's pumped from the heart with each ventricular contraction, or this is going to be a volume of blood that's ejected out each heartbeat. And the normal stroke volume is anywhere from 50 to 100 mLs. So if you have a heart rate of 70, for example, what then will be your cardiac output? Your cardiac output would be 350 or 3,500, I'm sorry, correct? So the normal cardiac output, this is the normal stroke volume, 50 to 100. And the normal cardiac output is anywhere from 4 to 8 liters per minute. Okay, so this is very important in order for us to understand why is it that sometimes compensatory mechanisms do not work. And the reason why they don't work is because if you increase heart rate without increasing stroke volume, it's not going to increase the cardiac output at all. So with this in mind, cardiac output is going to be one of the things that we're going to be looking at whenever we are looking at heart failure. But let's take a look at the variables of left ventricular function. And the first one is the concept of preload. This is also known as the end diastolic volume. This is the amount of ventricular stretch at the end of diastole. And I always want to discuss preload or liken preload to you moving from one house to another. So supposing that this is your old house and you are now going to go to a bigger house. I should have made this, okay. All right, that's the door supposed to be, and this is the window, okay. All right. So if you're moving from house A to house B, you're going to be renting a truck, a U-Haul, right, to move all your things. So the amount of furniture that you pack over in here is going to be likened to preload. So the amount of blood that goes into the heart, particularly the right atrium, is going to be known as the preload. So the higher the amount of blood that goes into the right atrium, the higher the stroke volume is going to be. So that is what is known as preload. Now, when you arrive at your new house, you have two doors, one in the front and one in the back. And the one in the front is larger than the one in the back. So this is door number 1 and door number 2. Which one or which door would you be using to unload your volume from the truck? Would it be easier to unload it and enter into house B through door 1 or to door 2?
1.
Door 1. Why is that?
It's bigger.
It's bigger.
Yes, it's bigger. All right. So if it's bigger, it's a lot easier for your furniture to go in, isn't it?
Yes.
And that is likened to the afterload. So the afterload, supposing now that the heart is going to pump out, it would be easier for the heart to pump two blood vessels that are going to be wide, like mark A, versus mark B. So afterload is the resistance of the exit of blood from the heart. So that if you are vasodilated, what happens to your afterload? Is it going to be decrease or increase? Is the afterload going to be increase or decrease?
Decreased.
Decrease. Okay. Yeah, it's going to be decreased. If you are vasoconstricted, then it is going to increase. So I hope that you understand now what preload is and what afterload is. So preload is the amount or volume of blood that is going to arrive at the right atrium. And afterload is the resistance against which the left ventricle has to pump blood through all the blood vessels. So if you have vasodilation, you're going to have a decrease in afterload. If you have vasoconstriction, you will have an increase in afterload. So these concepts are very, very important in discussing heart failure so that you will understand how we treat it and how we manage heart failure. So that's preload, the amount of ventricular stretch at the end of diastole, and afterload, the force against which the ventricles have to overcome to eject blood. Now, there's another factor that determines cardiac output, and that is myocardial contractility. If your contraction is going to be less, then you're going to have a decrease in cardiac output. If you're going to have a forceful contraction, you're going to have a normal or an increase in cardiac output. So all these three variables of left ventricular function are very, very important in order to understand the dynamics of heart failure. So another idea that needs to be said is that of the concept of ejection fraction. Now, I don't know how we get this, but when I was young, I thought that when the heart contracts, it ejects all the blood that is contained in the left ventricle, for example, or in the right ventricle. Well, that is not true. The volume of blood, let's say that this is the left ventricle, and this is the volume of blood right over here. When it contracts, it only actually ejects 55% to 70% of its volume. So we have to think, therefore, that ejection fraction is a measurement expressed as a percentage of how much blood the left ventricle pumps out with each contraction. So when we say that an ejection fraction is 60%, that means to say that 60% of the total amount of blood in the left ventricle is pushed out with each heartbeat. This ejection fraction actually will tell us then how our heart is pumping out blood, and this can be a diagnostic marker for heart failure. All right, so whenever we have an ejection fraction that is going to be less than 40%, then this is now going to be a manifestation that the heart is not pumping enough blood, and therefore it may be failing. So an ejection fraction of 40% is suspicious, therefore, of heart failure. And therefore, we are going to diagnose or to implement diagnostic measures in order to confirm the diagnosis of heart failure. Okay, so whenever we are looking at ejection fraction, the normal is anywhere from 55 to 70%. And thus, if you are going to be lower than this, then that means to say that the heart is now failing. So let's go to the pathophysiology of heart failure. And let me just go to my drawings over here. All right. So whenever we have heart failure, there are two types of heart failure. And one of them is what is called a systolic heart failure. And the other one is what's known as a diastolic heart failure. And how do they differ? Well, in systolic heart failure, the heart cannot pump enough blood. And the reason for this is because of the decrease in the ability of the heart to contract well. So let's say that the blood is going here adequately and going into the left ventricle, but then it is not going to pump 50 or 60% of the blood out. The reason might be because maybe the walls of the heart are going to be thinner, and thus, if it's thinner, the muscles are going to be less. So this is an example wherein we now have a ventricle that's full of blood, but because of the lessened area of muscles to eject blood, there's going to be a decrease in ejection fraction. So that is one pathology of your heart failure. That is what is known as systolic heart failure. So the volume of blood that's ejected is going to be diminished. And the reason why it is diminished is because of the fact that you might have thin walls of the ventricles. And what would cause the thinning of the walls of the ventricles? While stretching the ventricles for so long or in a chronic manner, it's going to thin out the walls of the ventricles. So when is it that this might happen? Well, in cases of cardiomyopathy or enlargement of the heart. So enlargement of the heart could be due to hypertension, for example, or maybe due to death of cardiac tissue. So when do we have death of cardiac tissue? In myocardial infarction. So these are the most common causes of systolic heart failure. So now we know that in systolic heart failure, the ejection fraction is going to be diminished or less than normal. And we said that if you go back to the previous slide, our normal is anywhere from 55 to 70%. And if the ejection fraction is less than 40%, this confirms the diagnosis of heart failure. The other way in which we have a heart failure is that there's going to be thickening of the muscles of the ventricles. So in here is a normal heart. Look at the thickness of the muscles. So it's able to accommodate all this blood right here. Okay. But in an example of a situation wherein the muscles become hypertrophied, such as in hypertrophic cardiomyopathy, there's now thickening of these muscles. So this, therefore, contains lesser volume. In this type of heart failure, the output or the ejection fraction is going to be decreased because you have lesser volume. So the contraction is not a problem. The heart contracts well, but because there's going to be lesser amounts of blood that's going to be in the ventricles, you therefore will have a decrease in cardiac output. So this is a type of heart failure wherein the ejection fraction might be normal. So that is the reason why there are several ways in which we could classify heart failure. We could classify heart failure based on the ejection fraction. There is a heart failure with reduced ejection fraction, such as what I had demonstrated when the walls of your heart are going to be thin. But there's also heart failure that is going to be having a normal ejection fraction. And that is exactly what happens in the thickening of the walls of the heart. So the other ways in which we could classify heart failure is whether or not it's acute or chronic. Acute means to say that the onset is immediate, and chronic is going to be a situation wherein the state of heart failure is going to be prolonged. And lastly, heart failure could be left, right, or both right and left side. So those are the pathophysiologic mechanisms of heart failure. Let's now go to left-sided and right-sided heart failure. So what are the distinct findings in patients with left-sided and right-sided heart failure? So let's go to this one. Okay, so let's go to failure of the left, because this is going to be much more common. So left-sided heart failure. So if you have the right atrium and the right ventricle over here, the next is going to be the lungs, isn't it? And then it goes into the left atrium and then the left ventricle. So this is not functioning well. There's left-sided heart failure. So if this is going to be similar to a traffic or a road, and this area is not functioning well, right there, where would congestion be occurring? Is it going to be point A or point B? Where would congestion, if the cars are coming this way, will your
A.
congestion occur in A or in B?
A.
A. All the cars will be in here, right? They will all be congested right over here. So look at the illustration over here. When the left side is going to be failing, therefore, the traffic is going to be congested right in the lungs. So in left-sided heart failure, the majority of your symptoms are always going to be pulmonary in manifestation. So the patient will have shortness of breath, they might have cough, they might have rouse, they also might have pulmonary edema. So those are what happens whenever you have left-sided heart failure. So you will always have pulmonary congestion as a manifestation. And because there's going to be pulmonary congestion, there is going to be impairment in gas exchange. Furthermore, if this were the alveoli in the in the lungs, and these were the blood vessels surrounding the alveoli, this becomes full. It becomes distended because the traffic cannot move forward. And so what happens when you distend the walls of the arteries? Do the arteries or the capillaries become smaller or thinner? I mean, thicker. If you stretch a rubber band, for example, does the rubber band, the walls of the rubber band become thicker or thinner?
Is it thinner?
Thinner. Okay. So what happens is that the blood vessels loses its ability to be semi-permeable. Semi-permeability means to say that blood vessels are going to trap the bigger parts or bigger particles, such as your proteins or albumin. But what happens when you stretch it out, this albumin is going to come out over here and it will attract the water, and therefore water is going to go into the interstitial spaces of the pulmonary tree. And that is the reason why you cannot exchange sufficiently or efficiently oxygen and carbon dioxide. And the reason for that is this. Okay, so if I had a membrane like this and I have a high levels of oxygen over here, diffusion will penetrate this and therefore will be absorbed into the blood. The other thing is, if I have carbon dioxide over here that's richer, this is also going to go out this way, where it's going to be lesser concentration. So this is usually how gas exchange occurs in the lungs. However, now you have a situation wherein you put fluids in the interstitial spaces. So you now have fluid over here. You make it much more difficult, therefore, for oxygen to come in and carbon dioxide to go out. And that is the reason why you have impairment in gas exchange. Okay, so that's left-sided heart failure. The symptoms, therefore, are mainly related to congestion of the lungs and also decreased oxygenation or gas exchange levels. When I say poor gas exchange levels, that means to say you will have a decline in oxygen in your arterial blood and an increase in carbon dioxide in your arterial blood. So that's left-sided failure. Let's go to right-sided heart failure. So what happens when you have, sorry about that, right-sided heart failure? So we have illustrated right over here, left-sided heart failure. We're now going to illustrate, left side failure. We're now going to illustrate right-sided heart failure. So what is the connection right over here from the vena cava? The connection to the vena cava is going to be liver. And then also, so that's portal circulation and the GI tract. Okay, so think about that. And then, of course, your peripheral circulation. So this would include your lower extremities, for example. All right, so usually blood from your lower extremities and liver and the GI tract are going to go back to the heart, to the right atrium, and then to the right ventricle, then to the lungs, and eventually out into general circulation. Now, the problem is that this area of the heart is not functioning well. So again, this is where the traffic is. So where would traffic be backed again? So it will back up into the liver. So what would happen to the liver when you back up blood in there? It's going to enlarge. And what is an enlarged liver called? Hepatomegaly. All right. How about your abdomen? Blood will go back over into your abdominal cavity, and that is what's called ascites. And in your peripheral circulation, and this would be edema, peripheral edema. So the signs and symptoms of right-sided heart failure are not going to involve oxygen exchange. It does not involve either pulmonary congestion. So always remember that in right-sided heart failure, we do not have a decrease in oxygenation as well as an increase in carbon dioxide accumulation, nor do we have any congestion, pulmonary congestion symptoms, no cough, and so on and so forth. But what we could have in right-sided heart failure, because of all the accumulation of all this blood, is going to have weight gain. All right, so that is the difference between right-sided heart failure and left-sided heart failure. So in right-sided heart failure, the congestion is in the peripheral tissues and the viscera, and we have the characteristic venous congestion. So one of the primary things that we see as a manifestation of venous congestion will be your jugular neck vein distension. All right, so that's left side and right-sided heart failure. So we had already talked about systolic heart failure. In systolic heart failure, the pumping is the problem because you have less muscle force to contract, and therefore there's going to be a decrease in the contractility, thus a decrease in blood being ejected from the ventricle. The preload increases. In diastolic heart failure, there is a filling problem, and it could be as a result of the cardiac muscles stiff or maybe thin. The ejection fraction is normal, and the preload is either normal or decreased. So that's the difference between these heart failures. And heart failure could also be classified as compensated, meaning to say that there are compensatory mechanisms that are activated. What do we mean by compensatory mechanisms? Well, when the heart is not getting enough cardiac output, the heart now can adjust its heart rate by increasing it. So you remember cardiac output is equal to heart rate times stroke volume. So if you increase heart rate, you can increase cardiac output. So that's one of the compensatory mechanisms that's going to occur in order to normalize the cardiac output. But there are also other compensatory mechanisms, and that's activating the sympathetic nervous system. And there are several things that can be activated in the sympathetic nervous system. And one of them is actually releasing natriuretic peptides. And I will talk more about this natriuretic peptides in a little bit. But the other one is the renin-angiotensin-aldosterone system. What is the renin-angiotensin-aldosterone system? So if you remember, when we have a decrease in blood pressure, one of the compensatory mechanisms is what is known as the RAS. So that's a decrease in blood pressure. And this is the activation of the renin-angiotensin-aldosterone system. When we have a decrease in blood pressure, this is sensed by the JG cells of the kidney, the juxtaglomerular apparatus of the kidney. And they release a substance called renin. Meanwhile, in the liver, there is a substance called angiotensin phenogenase. And the combination of these two is going to form angiotensin 1. And angiotensin 1 circulates in the lungs, and it's now going to be converted into angiotensin 2. And angiotensin 2 is a very potent vasoconstrictor. And so if you constrict blood vessels, what happens to your blood pressure? When you constrict blood vessels, what happens to your blood vessels? I mean, blood pressure.
Does it increase?
Yes. So you correct this problem. So you increase the blood pressure. So at the same time, this angiotensin 2 is going to activate the release of aldosterone from the adrenal glands. And aldosterone has two functions. One is to save sodium. So when you have a lot of sodium, what happens to water? It goes towards it, right? And therefore, the combination of sodium and water increases blood pressure. And the other function of aldosterone is to eliminate potassium. Okay. This is going to be a lot of things that I am going to talk about here as a result of our discussion of RAS, because one of the things that we do in order to treat heart failure is actually to block this renin-angiotensin-aldosterone system. So, for example, if you block the conversion of angiotensin 1 to angiotensin 2 by blocking the enzyme that converts 1 to 2, that's ACE, you block it, that is ACE inhibitors. What then is going to happen to your blood pressure? It's going to decrease, it's going to eliminate sodium, and therefore decrease your preload so that the heart can pump properly, but it also saves potassium. Okay, so one of the interventions is going to be ACE inhibitors. And just remember that ACE inhibitors are going to prevent the formation of angiotensin 2, and this occurs in the lungs. So your ACE inhibitors are the ones that end in pril. So lisinopril, for example, captopril, all those medications are going to be captopril, okay, are going to be ACE inhibitors. All right. So when you have ACE inhibitors, you are going to decrease sodium. Do you understand why it decreases sodium? And you increase potassium. So note that the complication of the use of ACE inhibitors is hyperkalemia. Do you get that so far?
Yes.
Yes.
Okay. All right. So let's go further and talk about other interventions that you might have to use in patients with heart failure, and that is to block the effects of angiotensin 2. These are what's called ARBs, or angiotensin 2 receptor blockers. These are the medications that ends in sartan. So, for example, losartan, candesartan, and so on. So again, when you use ARBs, you're going to decrease, therefore, sodium, right? So you are going to don't make this happen because you're already blocking the activation of aldosterone, and you're going to increase potassium as well. So it's going to be the same actions and adverse effects related to the use of ACE inhibitors as well as angiotensin 2 receptor blockers. So this is renin-angiotensin aldosterone system. This is one of the things that the sympathetic nervous system does in order to compensate for a decrease in cardiac output. And the other one is the Frank-Starling mechanism, meaning to say that if you have a rubber band, well, this is not a rubber band, but this is a balloon. The more I stretch this, the more contractile it is. But let's say I keep on stretching it all the time, every day. What's going to happen to this rubber band? It will thin out. And therefore, it is only going to be effective up to a certain point. So this is going to be something that is a temporary compensatory mechanism, and therefore it is going to be immediate response to a decrease in cardiac output. But if it's a chronic one, what's going to happen is it actually will contribute to decompensation of the heart. And uncompensated, or symptoms are present, and there's going to be lung congestion as well as edema, because there's no effort of the heart to compensate for the heart failure that is occurring. So let's go to the first poll that we're going to have. Okay, so what is the correct answer over here? So let's take a look at it. Which patient teaching statement is not accurate on left ventricular system dysfunction? All right, signs include cough, difficulty breathing, and weight gain. This is accurate, so this is true. We're looking for something that's not true. It is important to monitor daily weights, fluid, and salt intake. It is important to monitor daily weights, fluid, and salt intake. Okay, so let's just take that as a question mark. Left-sided heart failure can lead to right-sided heart failure if left untreated. That's accurate. That's true. This heart failure can cause peripheral edema from venous congestion. Peripheral edema is going to be a sign of right-sided heart failure, right? So this is not accurate. So this is incorrect. So we're looking for something that it's not. So in both heart failures, we're going to monitor daily weights as well as fluid and salt intake because of the activation of RAS, if you remember. So therefore, this is a correct statement. So letter D is the incorrect statement. Remember, right-sided heart failure are going to be mainly peripheral symptoms, such as your hepatomegaly, congestion in the GI tract, ascites, maybe peripheral edema, and so on. Whereas left-sided heart failure is always going to be associated with congestion of the lungs and disturbances in gas exchange, meaning to say your oxygen levels as well as your CO2 levels might be affected. Okay, let's go to a second one. Okay, so let's see. Letter A, which statements regarding systolic and diastolic dysfunction are correct? So we're now trying to see whether or not you all understood what I was talking about earlier. Distinction is based on ventricular ejection fraction. This is true, okay? Because you remember that in systolic dysfunction, there's going to be a decrease in ejection fraction. In diastolic heart failure, the ejection fraction is preserved. So letter B, therefore, is correct. And letter C is also correct. Because if you remember, in systolic dysfunction, if this is the left ventricle, right? And let's say that this is going to be the ejection right over here. So you have a lot of leftovers right over here. So this is the preload, the one that is going to be ejected before contraction. So it increases in systolic dysfunction. So letter C is correct. Where is my pen? A, B, and C. Does everybody understand that so far? Why A, B, and C is correct?
Yeah, I only selected B and C. I wasn't sure about A.
A,
I
yeah.
knew D
Because
and E wasn't one, but I wasn't sure about A.
uh-huh. In diastolic function, the EF decreases as it is either normal or actually increased. And the preload is not going to increase because there's not a problem with contraction. It's just a problem that it's almost like two bottles of water. One has a good amount, full of water, and you're trying to contract it, but you cannot eject it all out because your hands are weak. That's systolic dysfunction. In diastolic, you have a bottle of water, but the water is the water that is in the bottle is very less, and therefore, even if you contract it very much, there's not going to be more water that's going to be ejected. Okay, so that's why letter D and letter E are incorrect. Okay, for as long as you understood that. All right, let's go to another question. Okay, so let's discuss this. Before we discuss the answer, and I'm going to give you an opportunity to answer again later on, let me just talk a little bit about this one. All right, so let's say that this is the right side of the heart, and we know that the right atrium is right over here, and the right ventricle is right over here. The valve that separates the right atrium from the right ventricle is the tricuspid valve. Now, if the tricuspid valve is going to, let's say, be very, very small as far as its opening, and this is what's called stenosis, what's going to happen? You're going to have an increase in blood congestion over on the right atrium. So it basically is going to cause right-sided heart failure. So tricuspid stenosis or tricuspid valve disease can cause right-sided heart failure. Now, what connects the right ventricle to the left side of the heart? Well, the lungs and the pulmonary artery and the lungs are right over here, and the pulmonary vein and the left side, left atrium to left ventricle. If this is disease, if the lungs is disease, such as in emphysema, for example, wherein you will have destruction of structures within the lungs, this is what is known as pulmonary hypertension. And pulmonary hypertension can also be a cause of right-sided heart failure, because blood comes over here, but it has a lot of resistance going into the lungs, and therefore this is going to enlarge. So think about that now, that those are the problems that usually are associated with right-sided heart failure. So tricuspid valve dysfunction, which is letter A, is going to be right-sided heart failure, not left-sided heart failure. So let's go now to the left side to see what are the common things that causes left-sided heart failure. Okay, so if you have, again, a situation here, the left atrium and the left ventricle is separated by the mitral valve. Let's say that the mitral valve is diseased, similar to the right side, So you will have a lot of congestion right over here, and therefore you will have left-sided heart failure. Okay? And the last thing is that if you have a condition wherein the blood vessels that are going to be the recipients of blood coming from the left ventricle are going to be constricted. And this is exactly what happens in primary hypertension. There is a lot of vasoconstriction in the blood vessels. You're going to have also left-sided heart failure. And lastly, if you damage this heart, these muscles like here, like in myocardial infarction, it could also cause a decrease in the ability of the heart to pump. So in going back to that question now, can you change your answers now and just on the chat box to see what your answers are now after I have explained that? Go ahead and put it in the chat box. Okay, very good. All right. Excellent. We learned from our mistakes. So now you know why it is that it's letter D and letter E, right? That causes left-sided heart failure. And right-sided heart failure is any disease of the right side of the heart, such as in tricuspid stenosis or in pulmonary hypertension. Hmm. All right. So when we take a look at this, are you all done? I want my chair.
Yes.
Okay. So let's take a look at the question. A patient has left-sided systolic dysfunction heart failure. Which are expected findings? Okay. Echocardiogram shows an EF of 38%. That would be true, right? And this one, if it is 65%, that's going to be normal. So that's not going to be true. Patient has frequent nocturnal paroxysmal dyspnea. This is also correct. So the correct answer here is letter D. Options A and C are both expected findings.
What
I
is
need to start yeah, what is that? I
what
need to
is
start my mind.
nocturnal?
Nocturnal paroxysmal dyspnea. This is nighttime. That every time when you have left side heart failure, it usually is going to be worse when you lie down. And so this is what's called nocturnal, which is nighttime, paroxysmal, which means comes all of a sudden, dyspnea. And so this is characteristic of left-sided heart failure. So remember, right-sided heart failure does not cause respiratory difficulties, but left-sided does. Get it now?
Yeah.
Okay. All right. That's okay that you're missing those because now I don't know about you, but I learned from not selecting the right choices. And that's why when preparation for Nclex, you are supposed to be taking a lot of exams because the more you commit mistakes, the more you learn actually. Okay.
Agree.
Yeah. So don't get frustrated if you get a lot of wrong items when practicing, because that's the only way that you're going to learn. Okay. All right, let's take a look at this question. Okay, so remember that in systolic heart failure, you have a decrease in ejection fraction, right? And in diastolic, the ejection fraction is going to be normal.
I see it after I selected it.
Yes, that's okay. As I said, I'd rather that you commit mistakes now because then you say, oh my God, yes. So now you are thinking and you caught yourself, right? Okay, good. All right, so the emphasis here is that the difference between left-sided and right-sided heart failure is based on the symptoms. And then the difference between systolic heart failure and diastolic heart failure is based on ejection fraction. Okay, remember that. All right, so what are some of the risk factors for the development of heart failure? Well, heart failure can affect actually both men and women, although the mortality is more in females, and I don't know why. And there are also racial differences. It is much more frequent in African Americans than in whites. And heart failure is primarily a disease of older individuals, affecting 6 to 10% of individuals over 65 years of age. Now, what are the risk factors as far as heart failure is concerned? Hypertension. Hypertension predisposes an individual to systolic heart failure, right? And diabetes. And why diabetes? We actually do not know how diabetes is going to predispose an individual to heart failure, except that we can deduce that diabetics are going to be predisposed to having myocardial infarction and coronary heart disease. Obesity, blood clots, stroke, virus, family history, and toxic medications are also going to be factors. And I also would like to underscore this: alcohol and drug abuse. The problem with cocaine is it's a very potent vasoconstrictor. And that is why here in our area, I used to live in Miami and I worked in Miami, and we have a lot of young individuals coming with symptoms of heart failure or myocardial infarction or stroke. And that usually is because of alcohol and drug abuse. So those are risk factors for it. Now, the causes, the direct causes are going to be coronary artery disease. Obviously, when you weaken the heart, when the heart is having problems with blood supply, and that is ischemia, or when the heart is going to be enlarged, such as in cardiomyopathy, caused by systemic hypertension, and also pulmonary hypertension and valvular heart disease, which I illustrated earlier with the tricuspid problem and also the mitral valve problems. All right, let's go to another poll. Okay, so the correct answers here are A, C, and E. And let's see why it's A, C, and E. We have alcohol abuse post-MI. And over here, asthma, it's not a risk, and hypoparathyroidism is not also a risk. In here, endocarditis. Endocarditis is an infection of the inner lining or the inner layer of the heart. And mitral stenosis, we all know that could cause heart failure. And letter D, lung cancer, does not have any bearing at all. And this one is uncontrolled hypertension and has the flu. Virus, but this one is the most frequent cause of heart failure is hypertension. So A, C, and E. Okay. Let's see. Let's go to the next one. Okay, so let's take a look at the choices. So we're looking for conditions that are often associated with diastolic heart failure. So in diastolic heart failure, if you remember the drawing, if this were the heart, the muscles are going to be very thick. And so there's going to be less blood right over in the ventricles that can be contained. Now, you could also have a normal heart, but if you constrict it with pericarditis, that is the inflammation of the pericardium, you're going to constrict the heart. Thus, the chambers, when they are constricted, are they going to accommodate more or less? They're going to accommodate less.
Yes.
So therefore, A is going to be a correct response. Hypertrophy means to say that we're going to have enlargement of the cells. So these are the enlarged myocardium. So yes, this would also be a cause of diastolic heart failure. And ischemic heart disease. If you are not going to have, let's say, if you delay the relaxation of the ventricles, then you can also have diastolic dysfunction. All right, so let's say that this is the heart and you're contracting like this, but then you're opening very slowly. That is also going to cause diastolic dysfunction. So usually when we have ischemic heart disease, that could also cause it. But the ones that are absolutely incorrect are fluid volume overload. That means to say that there is a lot of volume, and you remember that is a problem in diastolic failure. You have lesser volume, and therefore this is more for systolic. And stenosis, as I have demonstrated earlier, is going to be much more related to systolic failure or systolic dysfunction. Okay? All right. So to summarize the clinical manifestations of right-sided and left-sided heart failure, look at right-sided heart failure, hepatomegaly, venous engorgement, and this is usually manifested in the jugular neck vein distension, also known as JNVD, jugular neck vein distension. GI symptoms. What are the GI symptoms of venous congestion? Well, bloating, and also going to be ascites, are manifestations of right-sided heart failure, and then loss of appetite. For left-sided heart failure, look, it's all mainly related to breathing, dyspnea, shortness of breath, cough, crackles, and oxygen or gas exchange. You would have low O2 saturation. So these are the more common findings as far as right-sided and left-sided heart failure is concerned. And there is I was looking at the YouTube channel, and somebody said, for you to remember right-sided heart failure, remember our head. It might work for some people. And AO stands for anorexia and weight gain. Head stands for hepatomegaly, edema, ascites, and distended neck veins. And for left-sided heart failure, he says, remember DUCHAP and dyspnea or thopnia. The CHAP is cough, hemoptysis, adventitious breath sounds, and pulmonary congestion. Now, we did not talk much about the hemoptysis, but he was right about hemoptysis. So let me just go back to the drawing of the alveoli. If this was the alveoli, and this was the capillary bed, I told you that fluid is going to leak out. And sometimes blood might also go into these interstitial spaces, and therefore it could manifest itself with hemoptysis. Okay. Okay, so let's discuss. Do you easily get tired? Remember, they have oxygenation problems and gas exchange problems. So a manifestation actually of heart failure is going to be that, easily get tired. And in fact, a nursing diagnosis that's appropriate for heart failure is activity intolerance. That's a major nursing diagnosis for patients who have heart failure. Do you have swelling in your ankles? Well, this points to questions pertaining to right-sided heart failure, right? And are you eating more than usual? Well, this is going to be inappropriate because they should lose their appetite because they have a lot of bloating and congestion in the GI tract. And therefore, this would not be a fair question to confirm heart failure. And are you feeling depressed? Let's just put a question mark over here. And I'm going to go back to that to discuss it. Do you get up often during the night to urinate? Okay, so let's look at right-sided heart failure. When you have right-sided heart failure, you have peripheral edema. So if these were, let's say, this is your leg, and we had a lot of congestion in this area, right? And you remember why there was a lot of congestion in that area? The albumin was going out of it, and so water is going to come out. Now, during the night, when the heart has to pump less because we are resting, what usually happens is that the fluid that was collected on the outside of the vascular bed returns. And when you have a return of fluid into the vascular bed, you will now have an increase in urinary output. So usually these patients are going to have a nocturia, meaning to say that they're going to go to the bathroom quite a whole lot. This is also the reason why in patients who have right-sided heart failure, they usually go into left-sided heart failure because the amount of blood increases during the night. And therefore, it is going to be more blood returning into the right atrium, which now overwhelms the heart if they have systolic heart failure. Okay, so again, the night symptoms are going to be the following: that they can have nocturia, and the reason why there is nocturia is fluid trap due to edema is resorbed, meaning to say it's reabsorbed into the blood vessel. So when this happens, you will have an increase in fluids, increase preload. Any questions about that one?
Not a question, but for that answer, that selection, I only pick it because I remember when you said about the nocturnal paroxysmal. So I kind of, what do I call it now? I kind of base my answer off of that, even though I didn't know the reason why I was selecting it.
Wonderful.
So I just wanted to say that.
Now you know. Now you know. Okay. So one of the things that usually happens in people who are old, like me, is when they lose the ability to do the activities that they usually did when they were young. They become depressed as a result of the illness, the inability to do the activities that they used to do. When you have heart failure, for example, you might not be able to walk from here to go and pick up your mail anymore. That's going to be depressing. So this is also a correct answer. But again, remember what I told you. When it's SATA questions, only select the ones that you are sure of, okay? Because if you select more, the potential is that you're going to have more deductions for those things that you answered that you are not sure, okay? So that is a strategy for this Nclex. All right, so how do we diagnose people with heart failure? Well, what are some of the diagnostic interventions that we have to do? Well, ECG is very important. Ventricular or atrial enlargement or hypertrophy, as well as ischemia, is going to be very important factors to find out because they contribute to the development of heart failure. Chest X-ray. Why is chest X-ray very important? Well, it might show an enlarged cardiac shadow, for example, and therefore this is going to be also very useful. Sonograms like echocardiography and Doppler and transesophageal echocardiography may also reveal enlargement of the chambers, and that's why it's very important. And some of the scans, like your Muga scan or heart scan, or exercise or pharmacologic stress test. An example of that would be your thallium scan or your persantin scan. Those also could determine the presence of abnormalities in the motion of the pumping ability of the heart, and PET scan as well as cardiac catheterization for obvious reasons. And now on the right side, these are some of the things that we would also check: liver enzymes, particularly if the patient is going to have right-sided heart failure. There's no such thing as frog levels, they're drug levels is what I meant by that, as well as the other things that are listed over here. They're all peripheral, except for this one's, of course, pulse oximetry and ABG. Okay, so why thyroid studies? Thyroid studies have a bearing because if a patient has either hyperthyroidism or hypothyroidism, this could also precipitate heart failure, particularly if the patient is hyperthyroid, because it increases the tension on the heart. Okay, other diagnostic measures are natriuretic peptides. And one of the first natriuretic peptides is atrial natriuretic peptide. What are they? Well, these are hormones that originates in the heart, and they actually are released whenever there's a lot of distension of the heart. So example of that, therefore, is when you have a lot of distension in the atria, this is going to inhibit the activation of the renin-angiotensin-aldosterone system. So that's one protective mechanism by the body. So if you have an increase in ANP, that means to say that there's a lot of volume going into your atria. So that is one of them. The other one is what's called B-type natriuretic peptide. Again, these are secreted from the atria and the ventricles. And this peptides, again, is going to be excreted whenever there is a lot of volume that goes into it. And the other one is going to be your NT-proBNP levels. Again, this is going to be the same thing. These are hormones that are going to be released whenever there's a lot of distension in either the atria or the ventricles. So just remember that these peptides are released as a result of over-distension of either the atria or the ventricles. Okay, so the BNP is going to be more on the ventricles. The ANP is going to be the ones that are going to be in the atria. Okay. All right, I think you got that correctly. Holter monitor is a test in order to diagnose arrhythmias. And so this is not going to be appropriate for the diagnosis of heart failure. So letter D is the correct response. All right, we are past our 1 hour mark. So let's go ahead and take a 3-minute break. And then when we come back, we're going to talk about the case study as well as other things that we have not mentioned, including medicines. Okay, so let's take 3 minutes. Okay, welcome back. Are you all back?
Yes.
Yes.
Okay, great. All right. So I'm just giggling over here when Chantal said, I did not know what that meant, the Holter monitor. Okay. Yeah, that's okay because Holter monitors are the ones wherein you do an ECG. They connect you to this to a machine, a very small machine. Actually, I had one 2 years ago because I had severe bradycardia. And it's a very small machine, right, that put on the chest, and it monitors your electrocardiogram continuously. So when they take that out, they can analyze and look at the findings if you have had any arrhythmias during the past 24 hours. It used to be like a very big machine that you had to carry, but now it's a very, very small thing, like this size, and it's just going to be attached close to your chest, in your chest, close to your heart. So that's Holter monitor. All right, let's go to the medications. So earlier, I had talked about the renin-angiotensin-aldosterone system. So I wanted to now review that so that you can remember why we're using ACE inhibitors as well as angiotensin receptor blockers for the treatment of these patients. Okay, so you remember that normally in the body responds to a decrease in blood pressure. Let's say that I sit down. That means to say that my blood pressure is going to be more, but when I stand up, it will decrease my blood pressure. So normally the body will respond instantaneously with this decrease in blood pressure because the JG cells of the kidney is going to sense this low blood pressure. And with this, it's going to release a substance called renin. And in the liver, there is a substance called angiotensinogen that is also present. So the combination of these two is going to cause the formation of angiotensin 1. And in the lungs, there is an enzyme called ACE, angiotensin converting enzyme, that converts this angiotensin 1 to angiotensin 2. And angiotensin 2 is a vasoconstrictor. So if you are vasoconstricted, you will therefore increase your blood pressure. But there's also another effect of angiotensin 2, and this stimulates the release of a substance from the adrenal gland called aldosterone. And aldosterone has two functions. It saves sodium. And so whenever you save sodium, you increase blood pressure because water usually is drawn with sodium and therefore increases blood volume. And the second one is, or the second function of aldosterone is it eliminates potassium. Okay. So the first kind of drug that we're going to be using is ACE inhibitors, which means to say that these are drugs that breaks or interrupts the conversion of angiotensin 1 to angiotensin 2 right here. So we're not going to have this happen. And so when you block that, you will not have vasoconstriction, you will not have release of aldosterone. So that is the action. It inhibits conversion of angiotensin 1 to angiotensin 2. And medications are captopril, lisinopril, enalapril, ramipril, and perindopril. These are all the medications that ends with pril. So always remember that prils are angiotensin converting enzyme drugs. And the side effects, it stands to reason, is going to be hypotension. And right over here, where does angiotensin converting enzyme reside? Do you remember where it resides? In the lungs, yes. And therefore, if you interrupt that, there will be a non-productive cough. And this is a common question in Nclex. This cough is something that cannot be treated with anti-cough medications. So it's something that you have to teach the patient that this is a normal, expected adverse reaction. And in fact, if the patient cannot tolerate that, that would be the reason why we would go to angiotensin 2 receptor blockers. All right?
That happened to my sister.
Oh, yeah? Wow. It is so bothersome. Patients, when I used to practice as a nurse practitioner, and patients would come to me complaining of cough, and you don't know that they are on ACE inhibitors. And when you ask them, and they say, I'm taking this medication, and you say, oh, that is it. I mean, that's the reason why this patient is coughing. The other thing I want you to remember is this hyperkalemia. It's a common question in Nclex. So do you understand why it's hyperkalemia? Because when you block this thing, you're going to decrease sodium, but you're also going to increase potassium. Do you understand that? So always remember that. This is a common question in Nclex. An adverse effect on the use of angiotensin converting enzyme inhibitors is going to be hyperkalemia and a chronic cough. Okay? All right, so the angiotensin receptor 2 blockers is you're going to actually do your blocking right over here. So you're blocking the action of angiotensin 2 on angiotensin 2 receptors. And they are the drugs that are ending with sartan, losartan, valsartan, candesartan. And again, it is the same side effects as the ACE inhibitors because basically they're acting in the same areas. All right. Beta blockers are drugs that ends with olol. So as you could see over here, olol. And if it is only ol without an olol, so usually, when the ending is different from olol, but it's still all, like alol or all only, then that means to say it's an alpha and a beta blocker. Okay, so beta blockers decreases. The reason why we give beta blockers is it's a negative inotropic agent, meaning to say that it decreases the force of contraction, and it is also going to decrease heart rate. So by doing so, you're decreasing the demands for oxygen. And that is why you're going to have this as a possible drug for the management of patients with heart failure. Now, remember, this is a negative inotropic agent. And so you will not use this in patients who have systolic heart failure. It usually is going to be more favorable in the management of patients with diastolic heart failure. Okay? Now, the complications that are associated with would be bradycardia and, of course, aggravation of asthma and low blood pressure. Because you remember, beta drugs are going to have an effect on, there are two receptors to beta, if you remember, beta 1 and beta 2. Beta 1 is in the heart. How many lungs do we have? We have 2 lungs. So it's easy to remember. So the action on the lungs is bronchodilation. But if you block this, what's going to happen? You're going to have bronchoconstriction. And that is the reason why this aggravation of asthma and other respiratory conditions actually would be a side effect. Okay. And digoxin. Digoxin is a positive inotropic agent, which means to say that it increases the force of contraction. So positive inotropic effect. It also decreases heart rate, and therefore this is going to help in your patients with systolic dysfunction. And the problem with digitalis is toxicity. So these are the side effects and manifestations of digitoxicity, including your visual disturbances. Usually a yellow haze is a claim that patients will have, and also GI disturbances such as loss of appetite. And then there's another drug called ivabradine, and it works on the sinus node. And this actually alters the initiation of sinus complexes or electrical current that goes into the sinus node. We really don't know exactly how it helps in the treatment of heart failure. So this is questionable, but we had found out that it really has a very positive effect on patients with both systolic and diastolic heart failure. And that is why it is an intervention that we do. So the actual mode of action for heart failure is not known, but we know that evidence shows that it is very, very effective. And the major problem or side effects is going to be bradycardia and AV blocks. So those are the medications that are going to be useful in the management of patients with heart failure. So there are other interventions, by the way, that we could do in order to help patients with heart failure. And one of them is an implantable cardioverter defibrillator. It does not help to treat the heart failure, but because these individuals are going to have higher incidence of sudden cardiac death, we therefore are going to have this as an adjunct to the treatment. It has been found out that patients who have heart failure are going to have high incidences of sudden cardiac death. And that's the reason why we do an ICD. And cardiac resynchronization therapy is this. Some instances, the right might be pumping and this is still relaxing, or vice versa. And so the cardiac resynchronization therapy is a therapy wherein you connect electrodes to both sides of the heart on the right and the left so that they can beat at the same time. All right, so it uses a pacemaker to treat electrical conduction defects. And then, of course, the ultimate one would be heart transplantation. So findings: Crackle's respiratory rate 25, SaO2 90 on room air, which confirms heart failure. Okay, so we actually didn't even talk about the normal values. And the reason that I didn't include that is because in the new Nclex, they usually will give you the values, the normal values. But nonetheless, anytime the BNP is less than 100, I think the unit of measurement is PG, something, PG per ml. If the BNP is less than 100, then that means to say there is no failure. And then, of course, the higher it's going to be, then it's going to indicate that the seriousness of the heart failure. So, for example, 100 to 300, that means to say that there is a present heart failure. And then between 600 to 900, that's moderate. And above 900, 600 would be severe. So that is exactly how this is measured. Okay, so the correct answer here is the BNP, letter B. Oh, oh, sure. Chantel, I'll go back to that one. Okay, so let's see. The correct answers here are going to be tachycardia, vasoconstriction. So it's not going to be bradycardia. It will be vasoconstriction and cardiac dysrhythmias. Um, So A and B is going to be the correct response because of the increase in sympathetic activity. Whenever you are talking about sympathetic, always think about epinephrine or adrenaline, because I'm sure that you know or you remember what epinephrine does. So what does it do to blood vessels? It causes vasoconstriction, and it also causes an increase in heart rate. So that will increase dysrhythmias. Unfortunately, these are going to be the only mechanisms that individuals who have end stage or late stage heart failure is going to have. Okay, so not bradycardia, but actually tachycardia. Not increased cardiac contractility either. That's going to be a decrease, increased cardiac contractility. Oh, that's the sympathetic response. Yeah, I'm sorry. Letter E is correct. Now, I'm also thinking that a patient who is having sympathetic stimulation will also have an increase in oxygen demand. So letter C is also correct. This one should be tachycardia. Okay. All right, so let me go back to the beta blockers because there was a question that I didn't see, and I apologize. What is happening over here? Whenever we have beta blockers, so beta blockers, and they block beta 1 and beta 2, so heart and lungs, right? So the side effects are going to be the following. So one of those that you are asking is glucose. What does it do to blood glucose? All right, so when you have epinephrine, you increase the breakdown of sugar. So you increase blood sugar. All right. That is why when you're stressed out, you would have an increase in blood sugar in order for you to be able to run and fight the enemy. Okay, so you will have an increase in blood sugar. But when you use beta blockers, you're going to block this effect. And so the patient is going to be at risk for the development of hypoglycemia. Okay, so in these patients, therefore, we usually try to avoid prescribing beta blockers to patients that are diabetic. But sometimes you have to take a gamble because the effect of the beta blocker is going to be the only course of action that will make the patient better. So when that happens, you have to warn the patient that the symptoms of hypoglycemia will not be detected. What are the symptoms of hypoglycemia? Well, tachycardia, for example. Well, because beta blockers causes bradycardia, this will not happen. Sweating. The patient will not be sweating because beta blockers also decreases sweating. And the tremors, which are associated with the first symptoms of hypoglycemia, are also going to be removed by or blocked by beta blockers. Do you know that beta blockers are actually the best for the management of test anxiety? When you are having, there are some people who really are very good. They know the material. But once they sit for a test, they lose everything because of an overwhelming epinephrine that's circulating around. And actually, the best thing to do for that is beta blocker. A small dose of beta blocker right before the test usually is going to have a very good effect. Okay, so if you're one of those, you might want to ask your provider if you could have a beta blocker just right before you go to take the exam. All right. So did I answer your question, Chantel, enough as far as beta blockers are concerned? Yeah. So that's two things, right? It decreases blood sugar production. So the patient is at risk for hypoglycemia. And the second reason is it masks the signs and symptoms of hypoglycemia. So no tachycardia, no sweating, no tremors. Okay?
Yeah.
All right. I don't know why it went to that one. I apologize. Okay. Okay.
You have the wrong poll.
Yeah, I know. So I ended that. I'm gonna end that because that's gonna be for the other one. I think it's this one. Yes. Okay, so the correct answers here are yes, we use diuretics. And the reason why, I might not have answered or explained this very well, why diuretics is going to be very useful. Now, if you have a weak heart and you're going to fill it with fluid, it's going to have more work to do and it causes the heart failure to be more. But let's say you have a weak heart, weak contraction, but you only put a few fluid in here, the ejection will be much better. All right. And that is the reason why diuretics are going to be very useful. Digitalis is going to be useful because it improves or enhances cardiac contraction. Non-steroidals have no bearing at all on the function of the heart and in heart failure. Beta blockers are going to decrease the demand for oxygen and decrease demand for oxygen is usually going to be represented by this MVO2. Okay, so if you see MVO2, this is the demand for oxygen. And then, of course, ACE inhibitors are going to be correct responses as well. All right, let's now go to the case study. And so the case study is a 68-year-old male client presents for a routine clinic appointment. He reports tiring easily when out shopping or for walks, has been staying home reading and watching TV, reports difficulty sleeping, awakens with shortness of breath in the middle of the night, reports 8-pound weight gain over the past 2 weeks, states normal appetite, denies chest pain and back pain, states he is anxious about his condition, no known allergies, current medications, enalapril. What is enalapril? You remember?
ACE inhibitor.
Yes, okay, very good. And also a hydrochlorothiazide, which is a thiazide diuretic, digoxin. Assessment alert oriented ×4, slightly anxious, heart rate 102 regular, plus 4 plus pedal and pretibial edema, respirations unlabored, crackles in the bases bilaterally, abdomen soft, non-tender, bowel sounds active, skin warm and dry and intact, frequent urination, small amounts, clear yellow urine. Do you understand why he's having frequent urination? Do you remember that? The
Yes, because
edema
the fluid is trapped.
good. The trapped fluid is going back into the vascular space, and that's why he has to go to the bathroom often. Okay. So the temperature is 98.6, pulse 102, respirations 22, 170 over 100, 93% on room air, and the weight is 215 pounds. Which 4 findings are most concerning? And I think that was the, what slide is this? 39. Let's see. Yeah, I already ended that. Okay. So which 4 findings are going to be most concerning? Anxious. Is that going to be a top one? Psychological is always going to be last, right? Physiologic is going to be priorities. Okay. Are you concerned about the 4+ pitting edema? That's a lot of pitting edema, by the way, right? So I think that I would be concerned about this because it is a 4+ pitting edema. How about Rouse? Would you be concerned?
Yes.
Yes. Okay. So, and how about, remember, we have to only use 4. So frequent urination also, yes, but that's not going to be something that's going to be serious, right? Appetite, nobody will die as a result of just a decrease in appetite. Awakening at night with shortness of breath. Okay, this is, yes, this would definitely be one of them, right? And weight gain also would be one of them. That is going, and heart rate, definitely. The heart rate was
102.
How much was it?
102.
102, right there. 102. Okay, so that's not going to okay. 102.
Not that
So,
high, I would
yeah,
say.
not that bad, but the weight, how about the weight? 215 pounds. That means to say that he's retaining a lot of fluid, isn't it?
Yes.
Yeah. So if it were me, I will just stop with this 3, but know that this weight gain is also bothersome.
Yeah.
I would also select this one, weight gain.
Because remember the edema,
yeah,
pitting edema.
yeah. So this one, I know you're not going to die right away from loss of appetite. The heart rate of 102 is not that significant, and frequent urination maybe, okay? So, but if I am very careful in answering, in choosing, I'm just going to go with B, C, F, then G, weight gain. Okay. All right. So let's go to the next question. Which abnormal finding should the nurse address first? Okay, so we have labs that's new. So cholesterol is 248, that's high. BUN is 10, that's normal. Creatinine is 1.5, that's very negligible. Remember, it's 1.4 is the normal. Hematocrit, now it's a male, right? So that means to say that this is going to be diluted. And hemoglobin is okay. Potassium 2.8. Uh-oh.
Yep, that one.
That would be dangerous for arrhythmias, isn't it? 135 and then 95. That's very negligible. Okay. Which abnormal finding should the nurse address first? Definitely that potassium, right? So you all agree with that one?
Yes.
Because it's too low. The danger of the potassium being low and not being treated is that it might cause, obviously, arrhythmias and cardiac arrest. And what is the arrhythmia that actually is associated with low potassium? It's a form of ventricular tachycardia called torsades de pointes. So this is ventricular tachycardia. Okay. All right, let's go to the next one. What should the nurse include in the teaching plan for this patient? This is 44. Hold on, I'm going to launch. There you go. Okay, so let's see how you responded. All right, letter A, weigh yourself every day at the same time and in the same clothes. This is going to be very important for anybody who is heart failure because an increase in weight means to say that the patient's heart failure is getting worse. So we're going to select this one. So this is correct. Increase intake of oral fluids. This is going to increase the demand of the heart. So that would increase the workload of the heart. We would not want to do that. Limit sodium in the diet to no more than 2 grams per day. That is exactly a good intervention. And immediately report 1 pound weight gain in 1 day or 3 pounds in 1 week. This is a little bit, for me, if I just ate a little bit more at night, during the morning, I will have a 1 pound gain. But usually, if you have a 3 pound weight gain in 1 day or 5 pounds in 1 week, this is going to be significant. This means to say that you're trapping or retaining fluid. Okay, so 3 pounds in 1 day or 5 pounds in 1 week. And limit exercise and physical activity. There is one clue I will want to share with you, and that is that we would never want to limit physical activity on patients unless they are dying. Okay, because of the fact that activity improves cardiac function as well as mental functioning. So this is going to be a good choice.
Even with the dysrhythmias.
Huh?
Even with the dysrhythmias, because that's what I was thinking.
Oh, I'm
That
sorry.
it would put too much work on the heart.
Right. So it says limit exercise and physical. Why did I encircle it? I'm telling you not to choose this because you encourage physical activity.
Oh, I thought you're saying it is an answer because I know
No,
I didn't
you
select.
need to
Okay.
encourage because, if you limit physical activity, then it's going to decrease their overall functioning as well as mentally, they're going to be much more depressed.
Okay.
Take prescribed medication every day. Of course, that is okay. Eat foods high in potassium.
I say yes.
Yeah, but you remember
The
is
hyperkalemia.
the patient on, let's see, is the patient on ACE inhibitor? We don't know, right?
Oh, she's
We
taking
don't.
lisinopril. Well,
Oh, yeah, right. He
she's
was
taking
taking,
lisinopril.
oh, come on, go back. He was taking lisinopril, right?
Mm-hmm.
And hydrochlorothiazide. I can't.
Yes.
Oh,
Enalapril. Sorry, enalapril.
but he is having a potassium of 2 point something.
Exactly. So that's what I was saying to increase the potassium because of that.
He had a low potassium. So this is tricky because if you remember, one of the complications of ACE inhibitor is what?
Hyperkalemia.
Hyperkalemia. But because that is a tricky one, but because the potassium here is 2.8, yes, we would need to encourage foods that are high in potassium. That was a dirty trick. Okay. Okay, so letter G is correct. All right. All right, so there's a medical order now. Where's the medical orders? Order. There you go, 10:30. Discontinue digoxin and begin sacubitril and valsartan. This is going to be a ARBs, okay? And this is going to be an ACE inhibitor. along with a dietitian consult, begin low sodium diet, fluid restriction to 1500 in 24 hours, weigh daily and record, and return to clinic in 3 weeks for follow-up. Okay, so remember that discontinue digoxin, begin sacubitril and valsartan, and dietary consult, low sodium diet, and fluid restriction. Okay, so which of the following actions should the nurse take in response to the change in the medical orders? Question the new medication order. The new medication was sacubitril valsartan. Okay. Can we do it one at a time? Would you question the new medication order?
Mm,
You remember the patient was already on enalapril. Remember
yeah,
that?
and
now,
hydrochlorothiazide. Whoa.
yeah, and then now he's going to give us sacubitril and valsartan. That's double. We're now giving another ACE inhibitor and an
Yeah,
ARB. This is going to be no good, right?
question.
I would question the new order. I would question this new medication order. So A is going to be one of them. How about educate the client about stopping digoxin?
I say yes.
Yes. Okay. Very good. So they still need to continue, of course, checking their pulse and making sure that they're going to report any evidence or any symptom of irregular heartbeats. Instruct the client to start the new medication today, but we were going to question the new order. So I guess not, right?
Yeah, no.
How about tell the client to take an additional dose of diuretic today? Can the nurse do that?
No.
No.
No. All right, no. Request that the provider order a potassium supplement. Okay, because
Yes.
that was 2.8, right?
Yeah,
that
that's
would be
good.
good. All right. Ask the dietitian to meet with the client. That was ordered too. So I guess we need to do this. Letter F. And determine if the client owns a weighing scale.
Yep.
Because the order was to weigh the patient daily. Obviously, we're going to do this. There's nothing wrong with that. Okay. So that would be how we would do that. So let's take a look at the next one. On day 14, the nurse calls the client to follow up. For each finding, click to specify if the finding indicates that the client's status is improved, worsened, or is unchanged from his condition at the clinic visit 2 weeks ago. Sleeping in the recliner. Does that mean to say he's improved, worsened, or unchanged? Why would he be sleeping in the recliner? Do you know?
He's
Can't
probably
breathe.
having,
So
yeah,
he can breathe. So that means to say, is he improved or worse?
worse.
He's worsened. Okay, very good. Nagging cough. Improve, worsen, and change.
I would say unchanged. I don't remember what cough he had before.
Yeah, but if you're having cough now, what does that mean? You have congestion in your lungs, right?
Yeah,
Mm-hmm.
I'd say
So
worse.
this worsened, yeah. Pink tinge sputum. That's not
Worsen.
good.
Worsen.
That's not good. Difficulty catching breath.
Worsen. He's in bad shape.
He's in a bad shape. He needs to come back. The pulse rate. What was the pulse
It was
rate?
102.
But
It
Unchanged.
doesn't say if it's high or if it's low.
I
just
know
says
it
pulse.
didn't say anything about the pulse rate
Unchanged.
at the present, because over here Oh, here it is. Day
Oh, it says
14.
it's 90. Wife check
Right
pulse
here.
and it is 90.
And the pulse is 90. Okay, it was 120 before, isn't it?
It was 102 before.
102, right, 102. So this is an improvement. Okay.
Mm-hmm.
See, this is the one that's difficult because we're not on the same page. What is the question? So, all right, so the pulse is improved.
Mm-hmm.
How about the lack of appetite? It says, didn't say anything, right?
Reports lack of appetite
It
first.
just says lack of appetite. So is it improved, worsen, or unchanged? Is this worsen?
Unchanged.
But it says lack of appetite. So he is not having any appetite.
But it said that in the other paragraph too.
Yeah, so it's unchanged. Go back.
It says reports lack of appetite first and getting up twice per
To urinate, right there. Reports lack of appetite. So that means to say that this is a new finding. So this is bad. That means to say he has got congestion in the GI tract, which happens in right-sided heart failure, right? Okay, so yeah, this is worse. This is worsening. And how about getting up to urinate?
Worsening.
Worsening. And thirst, worse. Oh my God, this
He needs to go back to the hospital.
he needs to go back to the hospital quick. Okay. All right. So that ends
I have a
my
question.
Yeah, go ahead.
Why is it not unchanged for lack of appetite? Why is it worsened?
Because you remember lack of appetite is a sign that you are having heart failure, isn't it?
Right.
So yeah, so this is day 14. He's already at home. So which means to say that there is going to be this change because on discharge we did not have anything to say about lack of appetite.
Oh, okay, I got it.
Yeah. So it was a new finding that he has lack of appetite. So that means to say it's a worsening. Okay. So I failed to tell you that right-sided heart failure and left-sided heart failure can occur independently, but they can also be together. So right-sided and left-sided heart failure can occur together. And when that happens, you will have both the symptoms of right and left heart failure. Okay?
Thank you.
I enjoyed today, and so tomorrow we're going to have stroke as our our case study. Okay.
Okay.
All right.
Thank
You
you.
all have a good evening. Thank you so much for your participation, and I'll see you.
Thank you.
See you tomorrow.
You're welcome.
See you
Thank you.
tomorrow.
Okay. Bye bye.